of 2025. So, of course, GECO, as you know, is hosted by the GI Foundation in association with Project ECHO, University of New Mexico. These sessions are held weekly on a Wednesday. Please post any questions you have in the chat. So our first speaker up today is Dr. Eduan Deetlefs. He's in private practice here in Cape Town. He's got a very, very big IBD practice, so he's a real expert in the field. And Eduan's going to give us an overview on inflammatory bowel disease and cancer. Thanks, Eduan.
Thanks, Joel, and thanks for the invite. Are my slides okay? Everything okay? Can you see that?
Yeah, perfect.
Perfect. All right. So I'm talking on cancer and inflammatory bowel disease. So I'm starting with a sad case of mine that I saw a few weeks ago. He's a banker. That is AI's version of a sad banker. So 65 years old, background of coronary artery disease, hypertension, dyslipidemia, kidney stones, and non-melanoma skin cancer. Diagnosed with ulcerative pancreatitis in 1993. Did well for quite a few years on 5 ASAs, Mesavant, but then fled and tried on an immunomodulator, failed that, and eventually started on adalimumab, Humira in 2009. And he did very well on that for over 10 years. But in February 2021, that's when I first met him, he had a flare, and that's what his colonoscopy looked like. So the right colon didn't look bad at all. Some pseudopolyps and some more pseudopolyps on the left-hand side, but then left colon didn't look so well. Lots of ulcers, Mayo 3, active colitis. So his adalimumab was stopped, and he was instead started on vedolizumab and Entyvio in May 2021. And by January 2023, he was in deep clinical remission, or deep remission, asymptomatic, and his colonoscopy was repeated. And apart from scarring, significant scarring and pseudopolyps, more on the left, everything else looked pretty normal. Then by the end of last year, he had a few months of mild sort of intermittent symptoms. He needed the course of prednisone, and his calprotectin was marginally raised at 170. So I repeated his scope. And this time he had an active colitis, predominantly on the left-hand side, but very concerningly, he had this very nondescript sort of 2 centimeter mass in the lower rectum with endoscopic features to suggest invasive malignancy. And this is less than 2 years after the previous colonoscopy. And unfortunately, this was an invasive adenocarcinoma. His staging tests were favorable. On MRI, he didn't have any nodal disease. His CA was normal. And at an MDT, it was decided not to offer adjuvant, neoadjuvant radiotherapy and to go straight to surgery. So he had a laparoscopic low anterior resection and total colectomy because his colon was quite diseased, with an anal pouch at the same time and a covering ileostomy. But the histology of the resected sample was unfortunately very disappointing. So not only were the margins involved, it was a R1 resection, but 23 out of the 26 nodes were involved despite the normal appearing MRI. Interestingly enough, there was no underlying adenoma underlying this cancer. So, I mean, this is a very sad case, and I think the question is, could this have been prevented? So in preparation, I looked at some guidelines. These are some of the articles that I had looked at, and we're going to talk about inflammatory bowel disease and cancer. So there are 2 main drivers of cancer in IBD patients. That is inflammation-related malignancies. Most importantly is colorectal cancer, but also small bowel adenocarcinoma, intestinal lymphoma, anal carcinoma, and cholangiocarcinoma. The other main driver is immunosuppression due to the treatment that we give. And here the main groups are hematological malignancies, of which lymphoma is the most important. Next group is melanoma and non-melanoma skin cancer, and then more solid organ tumors for which there is a less established association, including urinary tract cancer, cervical cancer, and a few other rarer ones. So looking at inflammation-related malignancies, colorectal cancer is the most important. You know that this is the 3rd most prevalent cancer in the world, occurring more in males than in females. The risk in IBD significantly increased, but recent meta-analyses suggest that this risk is quite a bit lower than we thought in the past. Previous estimates were up to 15% cumulative risk of colorectal cancer at 30 years. But more recent estimates based on meta-analyses suggest that after about 10 years, your risk is probably about 1%. At about 20 years, it's about 2%, and that goes up to about 5% the further you go from 20 years. So overall, the increase is probably about twofold risk of colorectal cancer over the general population in the whole IBD cohort. So what are the risks for colorectal cancer in IBD? So I think there are IBD-related risk factors. So these include the extent of colonic involvement for both Crohn's, colitis, and UC, where pancreatitis obviously has more risk than limited involvement or even a proctitis. The duration, significantly increased risk of about 8 to 10 years after the diagnosis. The inflammatory burden, meaning the severity of disease over time. Disease-related complications like colonic strictures in particular and pseudopolyps. And then very strongly a history of dysplasia, puts you in a very high risk category. It's interesting that even microscopic inflammation carries a significant risk. So even if you have mucosal healing, in other words, endoscopically everything looks fine, you've got ongoing inflammation at a histological level, that remains a risk factor. What are the non-IBD related risk factors for colorectal cancer? So PC, importantly, this increased the risk of colorectal cancer threefold. So it gives you up to a 30% chance of getting colon cancer after 20 years if you have PC in the mix. If you have a first-degree family history of colon cancer, especially if it's young of age, less than 50 years, your age, the older you get, the higher the risk. Males, higher risk than females. And then don't forget about lifestyle, smoking, drinking, low physical activity, red or processed meat. So what are the pillars of colorectal cancer prevention? So first of all, control the inflammation by whichever means possible. So best medical therapy, and obviously those are talks in its own right. Just on a side note, mesalamine for the independent chemotherapeutic benefit, there's always questions about that. At one time, it was thought to be very chemo preventative due to multiple pathways involved in oncogenesis. It seems like meta-analyses are less convincing about its role. Then the next pillar, apart from controlling inflammation, is screening and surveillance colonoscopy, and don't forget to address lifestyle measures. So screening and surveillance by means of colonoscopy. When do we start? So all colonic IBD, so that's Crohn's, colitis, and UC, need to be offered a screening colonoscopy from 8 years after the symptom onset. So not when you made the diagnosis, because a lot of times we make the diagnosis only long after the symptom onset. Except if you have PEC. If you have PEC, you start with a colonoscopy from the get-go, regardless of disease activity or duration. The frequency of surveillance depends on your risk. So you risk stratify, and based on that, you determine the frequency of surveillance. So if you're high risk, you do colonoscopies annually. So that's family history of colorectal cancer less than 50 years of age, PC, colonic strictures or dysplasia, extensive colitis with severe active inflammation. If you're an intermediate risk, you scope every 2 to 3 years, and if you're low risk, you scope every 5 years. So what are the principles of surveillance? So you need to survey or during a period of remission, preferably because inflammation can obscure dysplastic lesions. You need to have excellent bowel prep and all the other parameters of a good quality colonoscopy. That goes without saying. You need to have high definition white light plus chromoendoscopy. So that's either dye spray or virtual chromoendoscopy. And this is especially true if you had previous dysplasia or if standard definition scope and not white light, not high definition is used. By using chromoendoscopy, you increase your dysplasia yield by a factor of 2. So that's interesting. I'm not sure how many of us follow those guidelines. So the trend has been, when I did my training, to take random biopsies, full biopsy every 10 centimeters, That makes for a lot of biopsies. Fortunately, that trend has changed, and we now take targeted biopsies. So you see something abnormal, you take biopsies. There's still a place for random biopsies if you have high-risk patients, and when, for some reason, you don't have high-definition scopes available or chromoendoscopy. So what we've said is basically in this figure, this is the echo guidelines. So high-risk, extensive colitis, severe inflammation, colorectal cancer, families to PEC, strictures, dysplasia, those you survey every year. And then if you're intermediate or low risk, either every 2 to 3 years or every 5 years. So the low risk typically is your patient with a limited or proctitis without any of the other risk factors. It's fine to scope them every 5 years. Basically the same on the AGA guidelines, when to start. They agree 8 to 10 years or from the get-go for PEC. They agree with what you should use, dye spray and high definition white light. And they also talk about targeted and non-targeted biopsies, and then staging biopsies, where you basically take biopsies to determine whether there is inflammation. And the same type of stratification and risk categories, determining how often you should do screening colonoscopies. So the terminology has also changed. I mean, when I did my training, we still spoke about adenoma-like polyps and DOLMs and flat dysplasia. That has gone out the window. So we now basically describe the dysplasia the same way we do in a non-IBD colon. In other words, using the Paris classification, etc. So you've got polypoid lesions, which are more than 2.5 millimeters tall, which is also the diameter of the sand biopsy forceps, and there you can have either pedunculated or sessile lesions. So Paris I 1A and B, or you can have non-polypoid lesions, which are the flat, elevated, flat, or flat depressed, so 2, A, B, and C. And then we don't talk about flat dysplasia anymore. We now call it invisible dysplasia. So this is where you take random biopsies. You don't see anything abnormal, but the biopsies come back as dysplasia. So now you've got your dysplasia, and now there are some very important decisions to be made. And this is a very busy slide with management recommendations. And I think it's busy and complex because I think the decisions are busy and complex. And I think there are lots of permutations that might influence your decision. So in the past, the trend has been to prefer surgery to treat dysplasia. I remember very little dysplasia on random biopsies prompting colectomies. The trend now is more of an endoscopic approach, either EMR or ESD, depending on the size.
Just a quick question.
Yeah.
You may carry on. I think he's on the phone. You carry on.
Oh, sorry.
Sorry, Eduan. Sorry.
Are you asking me?
Error.
Okay, I'll go on. So we now have an endoscopic approach, but I think endoscopic decision-making is quite difficult. And you need to know what you're doing. And very few of us do endoscopic intervention on colitic colons. So I think it's important to discuss these cases at an MDT, discuss with your surgeon, have the patient involved, because it's not just cutting out a lesion endoscopically. As you can see, there is very strict surveillance guidelines, even if you do endoscopy every 3 to 6 months in some cases. So it's got implications, and I think an expert opinion in these cases are valuable. And I think it's important to remember that even though the trend is endoscopy over surgery, that poor endoscopy is still a lot worse than good surgery. So keep that in mind. Don't forget about the pouch. So the colon is out, but the pouch is still there, and there's still some cancer risk. So you need to do annual pouchoscopies in high-risk cases, so prior colorectal dysplasia or cancer, PC, and persistent moderate to severe pouchitis. So back to our case, the unhappy banker. So did he have high risk or a moderate risk disease. So he had a pancreatitis, he had his disease for more than about 30 years. There was intermittent activity and he had some pseudopolyps. But the way I read the guidelines, he was still okay to have a surveillance colonoscopy every 2 to 3 years. And anyway, it was very difficult to motivate him after he's had his UC for 30 years to come more often than that. So could it have been prevented? I didn't see anything with the colonoscopy 2 years earlier, and there was no adenoma underlying this cancer. So I think this is bad luck. I think this is a very, very aggressive cancer, and we know that the pathways in IBD-related cancer is different than non-IBD. So I'm not convinced it could have been prevented. Just looking at the other inflammation-related cancers in IBD, small bowel malignancies. So you have small bowel adenocarcinoma. This is a very rare cancer in the general population, but in Crohn's ileitis, there's a 15 to 30 times increased risk over the general population. The risk factors are very similar to that in the colon cancer, so long-standing small bowel inflammation, strictures, although the stricture risk is less associated with cancer than the colonic stricture. But fistulas, prior resections, males, and smoking. You also get intestinal lymphoma. There's a 2 to 3 times increased risk. And then there's a less strong association with neuroendocrine tumors. Anal cancer can be both squamous, where the risk factors are long-standing perianal disease, fistulas, and HPV infection. We have a 20 to 40 times increased risk. Or it can be adenocarcinoma. You can get adenocarcinoma in the fistulas. But fortunately, the absolute risk is still low. Cholangiocarcinoma is important in IBD patients with PC. There's an increased risk of cholangiocarcinoma in the order of 140 to 400-fold over the general population. There are some guidelines for screening in PC. I'm not sure how many of us adhere to these. So annual MRCPs and ultrasound and annual CA 19.9. And then importantly, annual screening colonoscopy as well if you have PC. So what about immunosuppression related malignancies? So as I've said, the 3 groups of immunosuppression related malignancies are the hematological malignancies, lymphoma, and to a lesser degree, leukemia and myelodysplasia, skin cancer, both non-melanoma and melanoma, and then others, other sort of more solid organs, cervical cancer, urinary tract cancer, and lung, and a few others. So talking about the hematological malignancies, the 2 groups that are important here are the thiopurine, so azathioprine and 6-MP, which carries a 5 to 6 times increased risk of lymphoma, especially as you get older from the age of 50 onwards. Most of these are B-cell lymphomas in association with EBV, Epstein-Barr virus, and there's also a lesser link to leukemia and myelodysplasia on the thiopurines. The data on anti-TNFs and lymphoma is a bit more conflicting. The risk seems to be in association with a combination of dual therapy with thiopurines, especially for this very rare cancer that occurs in young males with dual therapy, hepatosplenic T-cell lymphoma, that invariably leads to mortality. Immunosuppression induced skin cancer. So there's a definite link between thiopurines and non-melanoma skin cancer and anti-TNFs and melanoma, although that risk is also debated. And there's a minimal risk, increased risk for methotrexate and non-melanoma skin cancer. The recommendation is skin protection for all IBD patients, but more so if you're on any of these drugs, skin protection and yearly dermatological reviews. The problem with the new advanced therapies is we have got limited data, but so far there doesn't seem to be a signal for vedolizumab or ustekinumab, or for that matter, any in the IL-23 group for cancer. JAK inhibitors, there is a cancer signal in the rheumatological population, but not in IBD patients. So this is just, again, a schema indicating IBD-related and IBD therapy-related cancers in inflammatory bowel disease. So, I mean, this table is quite interesting. It shows the evidence level of association between various classes and the cancer. So, for instance, thiopurines have an evidence level 1 association with lymphoproliferative disorders, and anti-TNFs have a where's that? Have a evidence level 2 link. But for instance, methotrexate only have an evidence level 5 link with non-melanoma skin cancer. Sorry, anti-TNFs melanoma evidence level 2. So what happens if your IBD patient gets cancer, either active currently or previous cancer? So in that sense, I've got another case that I saw in the last week. So this is a 32-year-old female. She's from George. So that's Otaniqua Pass in George, which is very pretty. But she's far from me, so it's quite difficult to manage. But she has no comorbidity. She has Crohn's ileitis, which was diagnosed in 2020. She had short segment, mostly fibrotic disease, so we decided on ileocectomy prior to medical therapy in March 2021. And 3 months later, I did the colonoscopy. She had a recurrence, post-operative recurrence. She had Rutgers I2. So we started azathioprine in June 2021. 3 months after that, scoped her again. She still had active disease. We started delimumab and Javita in January 2022. And then just less than a year later, we did a follow-up colonoscopy. So this is the first colonoscopy after resection, shows minimal but definite activity in the terminal ileum. 3 months later, on azathioprine, looked pretty much the same. Not terrible, but it's not normal. And this is about a year after the Amjavita was started. We have a completely normal small bowel. So she did completely well and absolutely no Crohn's-related symptoms. But unfortunately, over the December holiday, she was found to have a superficial spreading malignant melanoma. Early stage, so resected with wide local excision and sentinel lymph node biopsy was negative. But she also has numerous other moles that will need long-term surveillance. So the question is now what she's doing so well on her Amjavita. She's far from me, about 500 kilometers. What we do now? So the management of IBD and active or recent cancer, basically, and what to do with the drugs relates to their risk of causing those cancers initially. So, I mean, for some associations, if you've got a lymphoma and you're on a thiopurine, it obviously makes sense to stop the thiopurine. That guidance is quite clear. Or if you have a melanoma and you're on an anti-TNF, you need to stop the anti-TNF. You don't really have much of a choice. But if you have a melanoma and you're on a thiopurine, then there's not much of an association. So theoretically, you can actually stay on the thiopurines. And there's very little data and recommendation is not to change if you're on an anti-integrin or an IL-23 or even a JAK inhibitor. But the data is limited because, what do we do? So that's for patients with active or recent cancer. What do we do with patients that had cancer in the past? Cancer is cured. It's just on the background for 5-10 years in the past. So we don't have good data here because these patients aren't involved in clinical trials. So we've got cohorts, amongst others, the SESAM and INADA cohorts and meta-analyses, and there doesn't seem to be a significant association between incident or recurrent cancer and immunomodulator therapy and anti-TNF therapy and recurrence of those initial cancers. So I think most important in these cancer cases is to share the misery and not only to have your hands up in the air, but also your multidisciplinary team, including your oncologist. So these are shared decision-making tools, and they're very unhappy because they've got like 8 fingers in each hand. So back to our case, we're going to stop her adalimumab and we're applying for vedolizumab. There are some cost implications. It's quite a bit more expensive and she's not on the best medical aid. And we do need to find an infusion center for her that will be able to deal with this. And then possibly we'll stop her azathioprine down the line, not because azathioprine is linked to melanoma, but we don't generally use dual therapy with vedolizumab. So in summary, cancer in IBD is driven by inflammation and immunosuppressive therapy. This risk can be managed by aggressively treating inflammation and by appropriate screening and surveillance. The absolute risk of immunosuppressive therapy-induced cancer is low, and the newer therapies hold the promise of further decreasing the cancer risk. Thank you very much.
Great, thank you, Eduan. It was an amazing overview and two very challenging cases. So I don't think there's any questions in the chat, so I'm just going to ask you a couple of things, if you don't mind, before you have to leave us. So do you think that this reduction that we've seen in colorectal cancer and IBD over the years is due to the better therapies that we've got controlling inflammation, or do you think it's probably because the studies have changed now, are more to population-based as opposed to sort of referral center bias?
I don't know for certain, Jill. I think you can argue it either way, but I think there's definitely some evidence that it's got to do with our more aggressive therapy, and also maybe we're getting a bit better in surveying these lesions and finding them earlier. I mean, saying that, I can't say that's true for my practice. I've only found cancers and very few just early dysplastic lesions.
Great. Chris, I see you raised your hand.
Chris, your...
Sorry. Yeah. Sorry about that interruption earlier on. Excellent, Eduan. Just on the first case, give us again the timelines of the endoscopic imaging. He fled in 2021. He had a colonoscopy when?
So at Index, when I met him, that's when he had his colonoscopy.
When he fled, 2021.
Yes.
And then when did he have, and the second, or the one that confirmed the cancer?
So the one that confirmed the cancer was just under 2 years after a normal colonoscopy.
Sure. So how do you believe that this was, this is de novo? Do you think there might have been an early lesion there that, this happens not too infrequently. This, by definition, this is an interval cancer.
Yeah, so I don't think one can completely exclude the fact that we missed something. But I think he's got despite very benign looking imaging, he's got basically all his nodes were riddled with cancer. So I think this is a particularly aggressive form of cancer, and I don't think it's impossible that there was nothing 2 years
previously.
Earlier.
No, we've seen them over years. Of course, I'm the kind of guy that will go into a whole guilt trip, and I'll hang myself from the ceiling and stab myself because I'm sure that I missed it. But we do see cancers, and particularly in patients who are at high risk with family histories, developing in under 2 or 3 years. So I think we've got to accept that this can happen.
Yeah, but as you say, it's very demoralizing because you do blame yourself. But even in retrospect, looking at those pictures, I don't think, I'm not sure how we could have done better. I must say, I do not do chrome endoscopy routinely in all my patients. I definitely don't do dichrome endoscopy in all my patients. So maybe there is room for improvement.
One last question for you, Eduan, before you head on your way. So you did mention that it's quite debatable whether mesalazine actually has a chemopreventative effect on colorectal cancer, and it's now recommended that patients who are on anti-TNFs in stable remission can actually stop their 5 ASAs. Do you practice that, or are you like me and err on the side of why not just carry it on?
So personally, I don't use 5 ASAs in any form of Crohn's disease. I don't think I use it in isolated colitis, but I always carry it on in UC regardless of whether they're doing well, but at a low dose. So I don't personally stop it because I do think it does something.
Absolutely. I'm glad you think the same.
Not necessarily for cancer prevention, but I think it does do something over and above your fancy biologic therapy to keep the inflammation controlled.
Absolutely, I agree 100%. Thank you very much for your time. Really appreciate it. Thanks, and hopefully we'll have you back here again sometime soon.
Thank you. Thanks, guys.
Sure.
Thanks,
Okay.
Eduan.
Cheers, Eduan.
Bye.
So our next speaker is Dr. Don Midden from Gauteng, and he's going to talk to us about a very interesting subject, which is alternative therapies in IBD. So if you want to start sharing your screen, please.
Hi, everyone. Can everyone see my screen?
Yes, perfectly.
Awesome. Thank you so much for the opportunity. As Prof said, my name is Midden John. I'm actually a gastroenterology fellow here at Joburg Gen. Dr. Siabi is my supervisor. And today, like Prof said, we're speaking about complementary and alternative medicine in inflammatory bowel disease. So interesting topic, obviously not as backed as you will see in the talk as we go, but definitely something important for us as gastroenterologists to keep in mind, especially when we're seeing patients, because they're going to come with those questions to you. Oh, is it moving?
It's not advancing at this
Yeah, it's not
time.
advancing. Of course it isn't, just when we start. 1 second, let me share again. Okay, round 2, it worked. Awesome. So what is CAM? So WHO describes it as essentially a broad set of healthcare practices that are not really part of the country's tradition or conventional medicine, however, and not fully integrated into the dominant healthcare system, but essentially can be used as complementary to the actual conventional treatment. And it varies from disease to disease. So today we'll be focusing, as I mentioned, on IBD. So why all the fuss about it? I found a very nice way to explain this from a study done in the Canadian Association of Gastroenterology, the journal. And basically what they did is they took 193 patients and sent out a survey about complementary and alternative medicine. Out of the 193, 58% were Crohn's disease patients and 42% were ulcerative colitis patients. And what I want to do is look at a few of the results that they found. In figure 1, as you can see, patients decided to use CAM based on advice from social circle, online, and physician. And you can see cumulatively, social network as well as online well outweighed our physicians. And this moves on to our second figure, where it shows that patients reported how well informed they felt about CAMs. And you can see a very small percentage were very informed, majority being somewhat informed and not informed. And you can then imagine that you've got not really informed patients getting information from social media and online and using it when we're trying to treat them conventionally can be a bit dangerous. And so another question that they brought up is, do you disclose your CAM use to your gastroenterologist? And we found that a majority do, but 32% did not disclose this to their gastroenterologist. And did they want to talk about it to their gastroenterologist? And 36% actually did not even want to talk to the gastroenterologist about the CAM. And so what it summarizes is that it's quite dangerous in that, one, we may be doing all this conventional therapy, but it could have a significant amount of interactions with what we are doing when patients use it without letting us know and without being informed. 2 is obviously the side effects that the CAMs can have. And 3, the adherence issues that may beckon there afterwards. And that's why I thought, with all of that, speaking about CAMs give us the opportunity to, 1, identify the persistent symptoms that patients may be experiencing, which lead them to using CAMs. 2, to essentially optimize our treatment as well as compliance with our patients. And then 3, improve our therapeutic sort of relationship with our patients when we are able to freely talk about CAMs to our patients, as well as inform them what might be good and what not be good. And another study basically showed me why patients do see CAMs. And the 4 big pillars that came about is the belief of a natural cure, 2, anti-inflammatory effect of the properties of CAM, anxiety of conventional medication and their side effects, as well as their perceived ineffectiveness of the conventional medication. And these are the big reasons why patients go and seek CAM without our knowledge as well as with.
Seem to have
improve.
lost audio. I've lost audio.
Sorry,
I can hear.
can you hear me?
I can hear you now, yes.
Okay, cool, awesome. So essentially, I was speaking about a specific carbohydrate diet that was brought about, and not much evidence was there for it. Then the low FODMAP diet came up as well, though we see it much more in IBS. It has been stated in certain research, but really not much to back it up at this point of view, like it is in IBS. Then there are a couple of nutritional things that have come up. So one is resveratrol, which is basically what we naturally occurring, and we see it in peanuts and grapes and red wine. Most of what you'll see now is all anti-inflammatory effects that all of these nutritional substances have. But with the resveratrol, it's not really completely understood as to how it works, but it does, in some studies, speak about abating colitis and preventing, as with the previous talk, potential cancer associated with colitis. But like I said, not a lot of big studies for it. Green tea has come up quite a lot in that it's anti-inflammatory and cancer preventative. And a lot of animal studies have been done to show that it is quite beneficial on animal tumors. It mediates essentially the effects with this anti-inflammatory effect. Then our fruits such as pomegranate, Punica granatum, essentially decrease our inflammatory response as well and is effective against colitis. Like with all of what I'm going to say, they still require further systemic and mechanistic sort of studies to make sure that this is actually good against colitis, but some studies have shown it. Rutin, however, it's essentially found in a citrus sort of fruit, tea, as well as buckwheat. I had to Google buckwheat seeds. But it's antioxidative as well as anti-inflammatory in rodent models. However, not much human trials have been done for rutin, so not really recommended at this point. Then our vitamins, our fat-soluble vitamins significantly decrease in Crohn's disease. And so supplying them with this would also help, and it's linked, especially vitamin D is linked to mucosal inflammation as well as disease activity. One strong nutritional agent came up as turmeric and curcumin, which we use quite a lot when we cook, at least I do. It's natural occurring, it's a root of the curcuma longa, and it's essentially its pharmacological property is anti-inflammatory in nature. So it suppresses your cytokines, it down-regulates the ICAM as well as Janus kinase. The only issue with turmeric that comes up quite a lot is that it's limited in terms of a systemic bioavailability. So there's poor absorption, there's high metabolism with rapid elimination. So there have been quite a lot of studies that have looked at turmeric, and it has shown some mixed efficacy in IBD. Specifically, there was a possible role in induction of mild to moderate UC with 5-ASA. However, like I said, all of the studies do recommend that they need a strategy to improve the bioavailability of turmeric. Fish oil came up, omega-3 fatty acids, and as with all the previous ones, it's involved in inflammation. It does benefit blood pressure, coagulation, neurological, but essentially the inflammation is what helps in IBD. And the human studies have basically shown that it does reduce a significant amount of production of inflammatory mediators, as well as decreases the inflammatory cytokines. And with fish oil, there have been multiple studies done. Although it is safe and well tolerated, there's still
a lack of efficacy in maintenance of remission in Crohn's disease, and mixed results were found with ulcerative colitis. And the final recommendation for most of these studies are we need further studies. Probiotics, however, most commonly used supplement that we have in IBD. The concept behind it is that it overpopulates your gut and it confers anti-inflammatory and immunomodulatory effects. And what I found is that the VS L#3, which basically has Bifidobacterium, Lactobacillus, as well as Streptococcus thermophilus, was quite effective with 5-ASA therapy in UC with mild to moderate. So that was quite a positive thing that came out of VSL#3. There is also a very strong evidence of using it in post-ileal pouch anal anastomosis in medically refractory UC as well. But currently, unfortunately, there's not much information or studies for its use in Crohn's disease. Wormwood is also something that came out quite a bit. However, it also works on the anti-inflammatory as well as anti-tumor and antimicrobial as well as antioxidant activity. But with wormwood, there was only about 2 small trials, and this was for Crohn's disease in particular. It suggested some efficacy, but there were issues in that they weren't really speaking about the adverse events of wormwood. And wormwood is known to have this toxin or neurotoxin called 2-John, which can cause seizures as well as psychosis. And so much more larger RCT trials are needed in order to back this and see if actually there are adverse events that are associated with it. So not really recommended at this stage. Aloe vera, which is our most common sort of natural remedy that has been used. On animal models, it does show that it really does help with our colonic tissue injuries and downregulates inflammatory mediators. And you know, in rat models, it showed to essentially decrease your inflammatory sort of response. It is well tolerated and it has no adverse events. This particular study looked at it and basically found that there unfortunately wasn't much endoscopic difference in the scopes, but space to work on and to develop further studies, as it is quite a nice tolerated sort of nutritional option. Then cannabis and medical marijuana essentially came up quite a bit. Currently, outside of clinical trials, not really recommended, but they are finding within trials that it really helps more essentially with quality of life and with symptom control, but not really much evidence to show that it is assisting in treating IBD at this stage. However, like I said, it's a lot of the studies are pushing that it helps them with their symptoms and makes them feel a lot better. Chinese medicine or Chinese herbal medicine came up quite a bit, in particular to the Andrographis paniculata as well as the Indigo naturalis. So with the Andrographis paniculata, there are still very big studies that are going on. Currently for both the Andro as well as the Indigo in Crohn's disease is not recommended, as there's no evidence rather. But with UC, there are phase 3 studies taking place for the Andrographis, but not really recommended in terms of Indigo for ulcerative colitis at this stage, as there's still a lot more information that is yet to be found in their research. But this is been pushed in a lot of the studies that Chinese herbal medicine is coming through. So just to summarize the nutritional and herbal camps, it's considered safe. However, efficacy and management is still lacking, and obviously adverse events and a lot of the ones that I mentioned above are still also lacking. So not all of them are safe. Curcumin, they found to be beneficial in induction and maintenance of UC, but not much evidence in Crohn's disease. Probiotics, not much for Crohn's, but for ulcerative colitis and pouchitis has shown to be beneficial. Wormwood, also limited, as well as aloe vera. But to summarize all of this, there's a need for further randomized controlled trials to validate the efficacy of these camps. At this stage, we have bits and pieces of information, but we need bigger, larger RCTs to back this more. And then we move to our cognitive physical approaches. Now, with that, one of the biggest things that was found in a lot of the literature is Chinese practices, so body-based interventions. So acupunctures, where they needle into acupoints, and then, as well as this moxibustion, which essentially they burn hot material and they put it in certain pressure points or points on your body rather. There's also the herbal one where they infuse it with the hot material that also they use to help. But essentially, with these practices, they're all quite safe because there's nothing really going into your mouth, so we're not worried about adverse events or side effects. So it is recommended, all of these things, which I'll go through now, that are complements to your conventional therapies. With acupuncture and moxibustion, it is a good complement to conventional therapy and overall safe. A lot of these essentially improve on quality of life of their depression, anxieties that patients with IBDs go through. And there is also little evidence to suggest that there's positive impact on inflammation or disease activity indices. So to go through it, CBT has come up quite a bit. Mindfulness for both UC and Crohn's disease, more particularly improving quality of life, anxiety, and depression. Hypnotherapy has come up in quite a lot of the research, as well as yoga, and most definitely exercise. I can only imagine, even without IBD, exercise is quite good. So it seems like this is just overall improving the quality of life of patients, as well as the mental sort of aspect of, or psychological rather, sorry, a psychological aspect rather of IBD that no one treats essentially. So the take-home message is, right now, complementary and alternative medicine is not really conventional, obviously, but it is important for us to know. We will have many patients come to us and asking about a particular drug or particular, whether drinking things are fine, but it's better to inform our patients rather than to ignore it, and also feel like it's an open sort of opportunity for you to identify their problems, chat about what the issues are, rather than them getting it from social media and online. There is unfortunately a lot of space for improvement with the research and development of many other sort of options that are out there. I do know there are a lot of different drugs that are still out there that are yet to be investigated. Like recently, there was a drug that was brought to my attention, BPC 157 peptide, which one of our patients spoke to my supervisor about, and unfortunately trials are still taking place and we don't know where it's going. So like that, a couple of them are taking place, but these are the ones that have been published quite significantly. Thank you very much. And these are my references.
Thank you so much for a fantastic overview. It's a very complex subject. So there are no questions in the chat. I don't know, Neo, if you want to make any comments, since I'm sure you have sort of been involved in this.
Yeah, so we came up with this topic particularly because a patient asked me about peptides, and he'd actually heard from another patient with inflammatory bowel disease that this particular peptide worked for him, and I obviously had no idea what he was talking about. So he then forwarded it to me. So yeah, we've had a patient with Crohn's who completely stopped her immune modulators and started to take curcumin. So yeah, I just wanted to bring it to everyone's attention that this is what patients are doing. Patients are taking these medications, so we have to be aware of what these medications are and potential drug-drug interactions, so that we can advise them properly.
Yeah, I absolutely agree. And of course, our patients are under the impression that natural medications are safe. And of course, as we all know, they're not. So, Lima, I don't know if while you were doing your reading, you came across any drug-drug interactions between herbal medications and our therapies that we use.
So, Prof, they didn't speak too much of it. Unfortunately, I wish they did, because I think that would have been a really big part of this. But most of the studies were just actually speaking about how well and how well they didn't. the interactions, unfortunately, not so many studies, but I can imagine when they spoke about adverse events is all they went as far as, but interactions, unfortunately, not. I think the assumption is that it will interact, I think, from all the studies, but nothing obvious, no.
Yeah, I don't know all that much about it. The one that I do know is St. John's wort, has lots and
Yes.
lots of drug interactions with IV drugs, and particularly with cyclosporins. So yeah, that's just something to think about. And then just a couple of comments. So the curcumin, yes, people do love that, but they don't appreciate the kind of concentrations or the kind of quantities that you actually need to ingest. And I think you did allude to this, are really not possible for people to consume for the benefits in ulcerative colitis. I don't know if you agree with that comment.
Sorry, Prof. I think my line just got cut off there. I think I heard a little bit of your last bit. Sorry.
Okay, so just the concentrations of curcumin that are needed to actually be effective in ulcerative colitis are actually extremely high, more than you would have by just sprinkling a little bit of cumin in a meal. Any comments on that? I think you sort of alluded to it. Are you hearing me? I'm not sure. Joel, can you hear me?
Yes, I can hear you, and yeah, I agree with you. Because like most people will have access to turmeric, and then they will take tons of turmeric, but we don't actually know the dose that would be required to bring about disease control. And also, it's just for mild UC. So I think people, like when patients take it, they don't necessarily know the severity of the disease. They just think, I've got UC, so this is going to work for me. Whereas it's not been shown to be effective in moderate to severe. So yeah, I agree with you.
Yeah. Okay,
Sorry,
and then just
it looks like my internet went off. Sorry.
oh, shame. No, don't worry.
Yeah,
Neo's kind of answered the question, so no stress there. And then I just want to make two comments. The first is probiotics. I don't really believe there's any place in IBD at all, except for, as you said, VSL3 for the prevention of recurrent pouchitis, and we certainly use it in our unit. And then there is one called E. coli Nisle, which is available in Europe, which has been shown to be pretty good for UC, but we don't have that available. Chris, I see you have your hand raised.
Yeah, thanks for an excellent presentation. If I can just share a quick anecdote with you, Jill, we've discussed this man in his 40s who developed ulcerative colitis, long-standing, failed biologic therapy, but developed a sarcoma on a biologic, which was stopped. He had curative resection with a splenectomy and a left nephrectomy and clearance of the sarcoma and in remission. But now what to do with his disease? And we suggested that he go to the surgeons and have the rest of the colon removed, which is very reluctant. And then we went through the whole discussion of perhaps a JAK inhibitor and et cetera, and he just is so reluctant. Calprotectin of 5,000, and he embraces complementary medicine, went on to a regimen of curcumin and also butyric acid. And calprotectin's come down to 400, and he feels terrific after 8 weeks. So I think the lesson, I mean, I wouldn't even take his calls when he said to me that's what he's doing, because I thought, I'm getting roped now into this, and I'm going to have this fulminant kind of, and his kidneys are starting to also slip a little. And I just felt I couldn't be part of this kind of complementary scene. But I think it's a lesson to all of us that you really have to embrace everything that patients bring to you and, lower your thresholds for evidence-based medicine. But I haven't scoped him, but he feels terrific, and the calprotectin has followed suit.
Absolutely. And I think we also have to be cognizant of cultural issues with our patients. So, for example, across sub-Saharan Africa, patients actually choose traditional medication and traditional healing over Western medicine. So, one's also got to respect their right to make that choice. Didi, I see you posted something. It was about cannabis and THC. We did discuss that already. But if you want him to just quickly give you a 1-minute overview.
So yes, medical marijuana essentially. Can you hear me? Sorry, I don't know. Yeah, I'm back. Not really used in recommended for use outside their current trials that are taking place. But like I mentioned, it's essentially just what they're finding in their trials that improves their quality of life more than anything else. But as I said, not for use outside of clinical trials at this stage. Not much evidence.
Great, thank you. Any other
Midden
questions
had-
or comments, Chris?
Midden had
you?
also. Hi.
Hi, no, yes, I can hear you.
So Midden had also said that, like in terms of cannabis, most for symptomatic relief, I think the particular symptoms, if I remember well, were things like nausea, for more for patients with Crohn's disease, and maybe some effect for abdominal pain, but no difference in terms of stool frequency or the other symptoms.
Sure, and we mustn't forget that obviously smoking marijuana is now legal, and that patients tend to mix it with tobacco. And of course, we all know that tobacco is really, really, really bad for Crohn's disease. So we must also bear that in mind. Okay, so
Sorry,
I think
Joe.
yes.
I don't know. Can you hear me?
Is that Debbie?
Sorry, there's a bad rainstorm in Joburg, so I think we're all sort of like have bad connection and can't hear each
explains why
other.
the connections have been on and off. Yeah.
Yeah, no. Just be having a lot of patients that I think especially for the pain and control of pain, especially the difficult, moderate to severe Crohn's disease, that then read about marijuana and pain and all of that after you finally get them off cigarettes or try to convince them to come off cigarettes. And I think most likely it's managing more of maybe the IBS component, especially the abdominal pain component, than anything else, and it tends to do more harm than good, obviously, in the Crohn's disease patients. But yeah, we see a lot of our patients here that are now taking up medical marijuana, and then not even the cannabis oil at the right doses, actually just smoking the THC, which is a different, obviously, a different mechanism. But yeah, I just wanted to make that
100%. Okay, so I think we're kind of running out of time. Unless there is any other very pressing questions, I'm going to close the session. So first, thanks so much to our speakers. That was really amazing. Great start to the year for IBD. Thanks to ECHO, University of New Mexico, and the ECHO India team. The recordings are, as always, available on the Gastro Foundation website. Thanks, of course, to the Gastro Foundation, to Chris, to Cheryl, and of course to all the sponsors. So next week's ECHO will be pathology, same time as today's session. So once again, thank you everybody for joining, and have a lovely evening, and we'll see you next time.
Thank you.
Thank you.